Hello, everyone. Welcome, and thank you for taking the time to join us for our virtual workshop today about START's approach to trauma-informed drug testing in child welfare. My name is Tina Willauer, and I'm the director of the National START Training and Technical Assistance Program at Children and Family Futures, or CFF. We're excited to talk with you today about this important topic in child welfare and how we in START have evolved our practice through the years to become more trauma-informed. Drug testing can be a contentious topic, so we hope you'll hear something today that's helpful to the work you're doing in your community. So again, welcome to all of our START affiliates and to all the others who've joined us to learn about START and the topic of trauma-informed drug testing. On the next slide, we're coming to you today from Children and Family Futures, or CFF, which is a national organization that specializes in the connections among child welfare, mental health and substance use treatment, the courts, and other family serving systems. In our work at CFF, we provide training, technical assistance, and evaluation services to communities, states, and tribes through multiple national, state, and foundation-based initiatives. CFF manages the National Center on Substance Abuse and Child Welfare, and we house the National Family Treatment Court Training and Technical Assistance Program, among many other great programming and resources available. And finally, CFF is the national home to the START model and to the National START Training and Technical Assistance Program. And CFF's the only TA provider for the National START model. And on the next slide, a little bit about the National START Training and Technical Assistance team. I'm Tina. My background's in child welfare, and I've worked in the child welfare system in various roles for over 30 years, all primarily in START. I have to say it's been great to help shepherd this model's evolution into an evidence-based intervention. I'm the model co-purveyor, along with Lynn Posey, who's here on the screen with me. Lynn's a senior manager at CFF, and she has a background in substance use and co-occurring mental health treatment, including trauma. We've worked together for over 17 years, and I couldn't do this work without her. We have 5 amazing and very experienced change liaisons who work with our START affiliates, providing training and technical assistance to help sites with implementation. We have a START evaluation TA provider who helps sites with data and evaluation, and a wonderful administrative coordinator. And they're all working behind the scenes today. So thank you, team. And on the next slide, I have the honor of introducing to you our guest speaker for today, Marla Heminger. Marla is a licensed social worker who currently works with Public Children's Services Association of Ohio as the training program manager for Ohio START. She brings many years of experience, having worked 20 years in the child welfare field and 12 years as the program administrator for the Ohio Department of Mental Health's Early Child Mental Health Program. She's also worked with childhood trauma programming at the local, state, and national levels, and is an affiliate member of the National Child Traumatic Stress Network, and just a wonderful colleague and partner in this work. So you'll hear from Marla shortly. We're going to move on to the next slide. And we're going to launch a poll, as we would love to know what system you work in and if you work in a START site. So we're going to launch those polls. And while you're doing that, I want to tell you about the plan for the day. So we're going to open with a brief overview of the START model to provide some context for today's discussion and to share our approach to serving families in the child welfare system. Then you'll hear from our special guest, Marla, for an overview of trauma-informed principles. We'll talk about how START is trauma-informed and how we can apply trauma-informed principles in drug testing. And then after that, you get to hear from a panel of people who work with START around the country. They're going to share their experience and their approach in drug testing. Now, there are a few things we want you to take from today's training. First, we'd like for you to understand trauma-informed principles, specifically with individuals with substance use disorders. We'd also like you to connect how trauma-informed principles are applied to the work you do with families. And finally, we hope that when you leave today, you'll be able to identify some specific areas of your own or your jurisdiction's practice that you may adapt to become more trauma-informed in your approach with families. Now, in case you were wondering, this is not a training about the technical details of drug testing, like the interpretation of test results or levels. If you have those kind of technical questions, we encourage you to reach out to your drug testing provider. All right, let's see the results of the poll and who's participating in today's event. Aha, we anticipated a lot of folks from child welfare, good amount of folks from the courts, our treatment providers, and other systems. And a shout out to our START affiliates. All right, welcome. Let's talk about START. On the next slide. All right. So the sobriety treatment and recovery teams model is an evidence-based child welfare service delivery model that's been shown when implemented with fidelity to improve outcomes for children and families affected by parental substance use and child maltreatment. Starts implemented by child welfare agencies, but in collaboration with their partners, so substance use and mental health treatment providers, the courts, and other family serving systems. What you see on the slide right now is a map of our current START affiliates. So START's been around since the 1990s when it began in Toledo and Cleveland, Ohio. Kentucky adopted START in 2007, where the model was rigorously tested, and it's been growing to new jurisdictions ever since. START's currently operating in 9 states, and we keep growing. So what is START? Let's talk about that on the next slide. So START's a child welfare-based intervention, meaning it lives in child welfare offices, serves families who come to the attention of the child welfare system due to substance use concerns, and who also have at least one child between the ages of 0 and 5. You want to think about START as a specialized unit or a team in your child welfare agency. It's not a treatment program or a curriculum. START workers are actually the child welfare caseworkers who provide ongoing services to families with open cases. START helps parents find recovery from substance use disorders to help keep their children safe and to avoid family separation whenever safe and possible to do so. START does this by using a group of strategies and a rapid timeline of early identification, screening, assessment, and referral for quick access to treatment services for families. Eligible families are engaged and offered treatment services far earlier than in traditional child welfare cases. And our research tells us that this early engagement of families, it results in more positive outcomes at the end of the case. And I'll tell you about that in just a minute. All this requires close collaboration and partnership with our substance use and mental health treatment providers to be able to provide those intense and coordinated services for families. Relying on crisis theory, we strike while the iron is hot during what might be considered a crisis with a new report to Child Protective Services. And we use that crisis to maximize the opportunity for engagement with the family. Who knows, the crisis might be the motivating factor in their decision to enter treatment services. START is grounded in family-centered practice, meaning we work with the entire family to help strengthen the family unit, improve parental capacity, and overall family functioning. Services are provided to each individual and to the collective family unit, and are focused on strengthening the bond and the relationship between the children and parents. The model's approach is strength-based, meaning we help families identify and build on their strengths, instilling a sense of hope and emphasizing that they are resilient and capable of reaching their goals because they are. Families are seen as partners in change instead of just recipients of services, and that's a paradigm shift that involves power sharing with families on planning and decision-making about their case. And finally, the model's used to transform how the system interacts with and on behalf of families, like a catalyst for systems change within and between child welfare, substance use treatment providers, the courts, and other family-serving entities. On the next slide, we're going to talk about a few of the main components of START. So staffing for START includes the pairing of a child welfare caseworker and a family mentor, and that's called a dyad. And together, the dyad shares a capped caseload of no more than 12 to 15 families. A family mentor is a person in long-term recovery who also has lived child welfare experience or experiences that sensitize them to how substance use disorders affect child safety and family functioning. They provide peer support services. They're housed at the child welfare office with the worker, and they're a full member of the START team. And they truly are the heart of the START model. Together, the dyad engages families and provides intensive child welfare case management services and support. Things like weekly home visits by the worker and the mentor. The family mentor actually escorts the parents, usually drives them to the first 4 treatment appointments to give that warm handoff for the treatment provider. They help with concrete supports to help remove barriers to the family receiving and participating in services and many other supports. START also partners with our treatment providers and others who are part of that team too. Families get a lot of attention and support in START. So central to START's collaborative and family-centered approach is the use of shared decision-making. Shared decision-making is used in all we do with families and within the team. And we recognize that every individual on the team, including the family, brings a unique perspective and should have a voice in the decisions made within their case. Nothing about me without me is the mantra. And for the professional team, this reflects a value that any decision or action regarding the family should involve the family, so there aren't any secrets or surprises. Program evaluation is an important component for supporting fidelity and outcomes for families, and data is used to inform our decisions in the direction of the program. All START teams engage in continuous quality improvement. So on the next slide, let's talk about the goals of START and what we're actually trying to achieve. First and foremost, to ensure child safety and well-being, to keep children in the home if it's safe and possible to do so, to support, encourage, and lift parents up so they have the tools and support necessary to enter into and sustain recovery. In START, our philosophy or our belief is that individuals don't have to hit rock bottom in order for them to receive help. And as one of our Kentucky family mentors put it, we can help parents raise the bottom. And I think that's just really true in the work that we do in START. We look to increase the knowledge, skill sets, and capacity of the parents to help them stabilize and strengthen their family situation. And START teams do this by building upon family strengths and increasing their capacity to protect their children so that repeat maltreatment is reduced. And finally, we work to create a new way of doing business by changing the system's ability to address co-occurring substance use and mental health and child maltreatment. We want all families, not just START families, to have rapid access to quality treatment services at the intensity level they need. On the next slide, the National START Model tenets are our fundamental beliefs, values, and the philosophy that underline our practice. They serve as a guide for START teams as they implement the model, serve families, and sustain the model over time. These tenets were originally developed collaboratively with a cross-system group, and they've been discussed, debated, updated, and used by sites ever since. It's really important that teams discuss the tenets together and remember these beliefs as they expand and evolve, always returning to them for guidance and inspiration. And on the next slide, at the heart of START is a philosophy or a spirit that represents how we approach individuals and families dealing with substance use disorder. In START, we approach them with compassion, understanding, and hope for recovery. This philosophy is woven through all that we do, from how we work as a team, supporting and holding each other accountable, to how we interact with families. We believe in family, love, and redemption. And you're going to see this spirit of START in the way that START staff are selected, in the way that START teams are built. It's reinforced during case reviews, START meetings, and in how decisions are made as a team, valuing everybody's perspective. You hear it in our language and how we talk about or to families, and in the model's non-punitive, strength-based approach. We see it as our job to role model this compassion and love in our communities and in our work with families. And on the next slide, let's talk about outcomes. A lot of rigorous evaluations have been done in START, and we've had numerous studies published in peer-reviewed journals. So here's an overview of those findings and what we've learned so far. Mothers in START had higher rates of sobriety and early recovery than a matched comparison group, 66% in START versus 37%. Children in START entered out-of-home placement at half the rate of children from a matched comparison group, 21% in START versus 42% in the comparison group. And I have to say that we've seen that outcome repeated in several of our studies. At case closure, more than 75% of children in START remained with or were reunified with their parents, and there were cost savings. So for every dollar spent on START, jurisdictions saved $2.22 just on costs associated with out-of-home placement. More on the next slide. Next, we did a study to find out if the effects of START were actually sustained beyond the intervention, meaning after the START child welfare case was closed. And the answer was yes. We learned that at 12 months post-intervention, meaning after the START case was closed, more children in START remained free from both out-of-home placement and recurrence of child abuse and neglect, as compared to children served in traditional child welfare services. So START at 68.5% versus the 56%. So as a follow-up to that sustained effects study, we did a study to test the effects of START on Black families. So after comparing outcomes for Black families in START and Black families receiving traditional child welfare services, we found that at 12 months post-intervention, so after that START case was closed, more Black children in START remained free of out-of-home placement and child abuse or neglect than Black children being served in traditional child welfare services. And you can see the numbers, 80.6% in START. We also learned that once involved with START, there was no evidence of differences in the services or outcomes across various populations. And finally, START's listed as having promising effectiveness on the California Evidence-Based Clearinghouse for Child Welfare, and START's listed as a supported practice on the Title IV Prevention Services Clearinghouse. This is important because it allows states to draw down Title IV prevention dollars to support and sustain the model, as long as START's included in the state's 5-year prevention plan. So that's a quick START overview, and hopefully that gives you a little context about how we approach child welfare services. Now, I'm going to turn things over to Marla. Marla?
Thanks, Tina. I want to welcome everybody. Say good morning or good afternoon, depending on where you were joining us from. So overview of trauma-informed principles. For this overview, we really, as Tina had said, want you to gain an understanding of trauma-informed principles and how they connect and apply to the work you do with families. But I do need to start in saying, we will be talking about trauma, and some of the content covered might cause uncomfortable reactions for trauma survivors. So we do encourage participants to step away if needed and take care of yourself and return when you're ready. So we need to say, if we're going to talk about trauma-informed principles, we need to start with what is trauma. So on the next slide, we have a QR code for you to use to submit responses during Mentimeters. So we'd like you to say, what is trauma? What word or short phrase comes to mind for you? So if you use your QR code with your phone, we'll create a word cloud for us to view together. So we'll be seeing this as you enter your responses. And on here, you see the QR code and also the Mentimeter user code that you got. Hurt, negative experiences, scared, pain, sadness, pain, hurt, absolutely, fear, long impact, struggle. Oh my gosh, it just, so much, absolutely, suffering, struggling, pain, fear, hurt. All these things are so important, absolutely. And we keep going. So hurt, pain, fear, sadness, struggle, all these things are involved with what trauma does. So thank you all for participating, and we will continue, as you continue to add things, we'll hang on to this word cloud also to share later. So what is trauma? On the next slide, just sharing a definition for you about what is trauma. So looking at especially the highlighted words, trauma is a person's emotional response to a distressing experience. The events tend to be sudden and unpredictable and involve a perceived serious threat to life and feel beyond a person's control. We know a traumatized person can feel a range of emotions both immediately after the event and in the long term. And I think people talked about that in the word cloud too. And this includes feelings of overwhelmed, helpless, shocked, or having difficulty processing their experiences. So let's talk about the 3 E's of trauma on the next slide. Our Substance Abuse and Mental Health Services Administration talks about the three E's as part of their framework for understanding trauma. We talk about events, experience of those events, and the long-lasting adverse effects of the event. So individual trauma results from an event, a series of events, or set of circumstances that is experienced by an individual as physically, emotionally harmful, or life-threatening, and has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, and spiritual well-being. So this definition recognizes not all exposures to traumatic events result in adverse outcomes. So for the events, again, there are many lived experiences and circumstances that may be traumatic. They may happen one time or happen repeatedly over time. People also can live with a high level of toxic stress that could be traumatic. And each person's experience of the events or circumstances differs. One person's experience may be more traumatic than for another person. Again, how we label and assign meaning to our lived experiences and how we are impacted physically and psychologically really contribute to how we experience events as traumatic. And we talk about the effects. Long-lasting adverse effects are a critical component of trauma. The effects of lived experiences of circumstances that may be traumatic, again, occur immediately or may have a delayed onset, and the duration can be short to long-term. So it could be challenging to see the connection between events and effects. They may include things like an inability to cope with normal stresses and strains of daily living, challenges trusting others in relationships, managing cognitive processes such as memory, attention, and thinking, resolving behavior or expressing emotions. And I think these are the populations that many of you work with, this would make sense to you. And again, on the next slide, want to talk about the experience of trauma, and it's affected by what happened, how did it happen, when did it happen, where did it happen, and how often did it happen. So again, the event could be a single event or something that happens more than once or is ongoing. And again, it may be just as traumatic if it happened once then, or even more than when it's a chronic traumatic event. So on the next slide, talking about the effect of trauma. Again, it can be, on an individual, it can be seen as a normal response to an abnormal situation. So on the next slide, we need to talk about, again, the responses. Is it a problem or was it a person's adaptation? So think about how people respond when a system is involved with them. Are a person's actions or behavioral, again, adaptations, or are they coping mechanisms to the traumatic events? And I think the question needs to be asked. It's not what's wrong with you, but instead, what happened to you? So we also know substance use often stems from trauma and acts as a coping mechanism. And when that coping mechanism is removed, people can experience fear, anxiety, guilt, and a return to use. We know many people with substance use disorders have experienced trauma as children or adults. It predisposes people to higher rates of trauma. People who use substances have experienced trauma have worse treatment outcomes than those without histories of trauma. And more than half of individuals who seek treatment for substance use disorder report one or more lifetime traumas. And a significant number of clients in inpatient treatment also have traumatic stress symptoms or post-traumatic stress disorder. So on the next slide, when we talk about trauma, I think it's important we talk about the adverse childhood experiences study. And many of you have probably heard about this. It's been around for a long time. It was a study that was conducted in Kaiser Permanente between 1995 and 1997. Over 17,000 members of Southern California receiving physical exams from their HMO completed confidential surveys regarding their childhood experiences and their current health status and behaviors. Again, the study participants in the beginning were 17,000, mostly white, middle upper class, college educated with good jobs and great health care. So the ACE study is also one of the largest investigations of childhood abuse, neglect, and household challenges and later life health and well-being. So the types of ACEs studies, as you see, was abuse, emotional and physical, or neglect, emotional, physical abuse, emotional, physical, and sexual, and household challenges that included domestic violence, substance use, mental health, separation, divorce, and incarcerated household parents. The first studies that were done showed us that childhood trauma was very common, even in employed, white, middle-class, college-educated people with great insurance. They're common across all populations. Almost 2/3 of the study reported at least one ACE, and more than 1 in 5 reported 3 or more ACEs. We found there was a direct link between childhood trauma and adult onset of chronic disease, as well as depression, suicide, being violent, and being a victim of violence. We know that more types of trauma increase the risk of health, social, and emotional problems. And of course, these are just 10 childhood traumas because they were the ones that were mentioned as being most common in this study. But we know there are other types also, such as losing a caregiver, homelessness, involvement with the child welfare system, involvement with juvenile justice and courts, school and community violence, disasters, accidents, medical procedures, poverty, and so many other things. On the next slide, we know, again, ACEs have serious health consequences. They can have a lasting effect on health and well-being in childhood and life and opportunities well into our adulthood. They increase the risk of injury, sexually transmitted infections, involvement in sex trafficking. They can increase risk for injury, mental health, maternal health, infectious diseases, chronic diseases, risk behaviors, and opportunities such as your education, your occupation, and your income well into adulthood. So research also supports a relationship between the number of ACEs and likelihood of developing a substance use disorder. So studies have indicated ACEs are associated with both an early age of substance use initiation and a greater likelihood of developing a substance use disorder. So individuals with high ACE scores are more likely to experience negative impacts from substance use, such as psychosis secondary to substance use and return to use during treatment. Again, going back to thinking about coping mechanisms. So I'd just like to share trauma and some data here from SAMHSA on the next slide. So up to 65% of all clients in substance abuse treatment report childhood abuse. So again, this is a common thing. Up to 75% of women in treatment report trauma history. I think this one is important too. 92% of homeless mothers have severe trauma histories, twice the rate of drug and alcohol dependencies as those without. And almost a third of all veterans seeking treatment for a substance use disorder have PTSD. So again, it's a very widespread thing. On the next slide, I'd just like to share briefly some of the results. In Ohio, for Ohio START, we do an adverse childhood experiences, an ACE questionnaire for all of our adults. And this is some of the results that we have. So what this looks at is comparison of Ohio START to general population, going back to the studies that have been going on. So in Ohio START, a score of 4 or higher is our threshold to make sure that we are referring the parent for further mental health trauma assessment and treatment. As you can see, the average score in Ohio START is 4.3. And parents in START score much higher than general population on having 4 or more ACEs, significantly higher. In the ACEs themselves showed that we're 108% higher than the general population and 24% higher than previous child welfare estimates in START. And the proportion of adults with 4 or more ACEs is 28% higher than previous estimates. And it's also important on the next slide, we talk about the children that are currently in START. So we use the Children's Trauma Assessment Center screening checklist. We call it CTAC tool. There's a tool for children ages birth to 5 and one for children ages 6 to 18. Both of them have the same trauma types. There are 14 different trauma types, and both screen for behaviors and symptoms related to the trauma exposure. But the 6 to 18 also screens for school-related problems. And again, children who score 4 or higher are referred for further assessment and treatment services. So when we look at this, again, 14 types of trauma of our children. You can see the dark purple are children birth to 5 and light purple are children 6 to 18. We know that children birth to 5 have higher percentage of trauma exposure from 1 to 4 trauma types, whereas our 6 to 18-year-olds, as you can see, have a higher percentage of trauma at 6 or more trauma types. So we're looking at a lot of traumas that happen with these children, which is not surprising with the population that we're working with. It also tends to highlight that children have more trauma exposures as they age. And again, they may have lived in a traumatic environment much longer. It also highlights the extent to which young children are exposed to trauma and the absolute importance of referring all children, including young children, for further assessment and treatment. We also know that in START, the children that we do have done the screens on score 27% higher than previous study estimates for the numbers of that they have. So on the next slide, I want to go back to talking more about what is a trauma-informed program. And we look at this as the 4 R's. So what is trauma-informed? It's approach to care that recognizes the widespread impact of trauma, promotes environments of healing and recovering, and it helps to seek and understand, respond to signs and symptoms of trauma in patients, in families, in staff, and avoid re-traumatization. So it's not just about the people we serve, it's about the people that serve the people. So it emphasizes really understanding life experiences. A trauma-informed program understands and tries to implement these 4 R's. So realizes in a trauma-informed approach, all people at all levels of an organization have basic realization of the widespread impact of trauma and understand how it can affect people, including families, groups, organizations, communities, as well as individuals, and potential paths for recovery. It recognizes that people and organizations recognize signs and symptoms of trauma of families and staff, the signs and symptoms, and trauma screening and assessment to assist in recognition, as do workforce development, employee assistance, and supervision practices. Also integrates an understanding that the experience of traumatic events impacts all the people involved, whether directly or indirectly. Everybody in the organization, from the person who greets clients at the door, to the executives, to the governance board, have changed language, behaviors, policies to take into consideration the experience of trauma among the children and adult users of the services and staff providing the services. And lastly, we also resist re-traumatization. We don't want to inadvertently create stressful or toxic environments that interfere with the recovery of clients, the well-being of staff, and the fulfillment of the organizational mission. We know that sometimes organizations that aren't trauma-informed may not recognize how their practices could provide provide painful memories and re-traumatize patients with trauma histories. On the next slide, we also talk about guiding principles of a trauma-informed approach. And again, these are from Sampson. These are the six key principles fundamental to a trauma-informed approach. Number 1, we talk about is safety. Throughout the organization, staff and the people they serve, whether children or adults, feel physically and psychologically safe. The physical setting is safe. Interpersonal interactions promote a sense of safety. Understanding safety as defined by those served is high priority. Second, trustworthiness and transparency. Operations decisions are conducted with transparency with the goal of building and maintaining trust with clients, family members of those receiving services, among staff and others involved in the organization. Next, we talk about peer support. And as you heard, peer mentors are an integral part of START, with peer support and mutual self-help being integral to the organization, the service delivery approach. And it's for establishing safety, hope, building relationships, building trust, enhancing collaboration, and utilizing their stories and lived experience to promote recovery and healing. Next, we collaboration and mutuality, recognition that healing happens in relationships and in the meaningful sharing of power and decision making. So the organization recognizes everyone has a role to play into the trauma-informed approach. As one expert stated, one does not have to be a therapist to be therapeutic. Empowerment, voice, and choice. This is so important. That we recognize the people. We aim to strengthen the staff, the client, family members' experience of choice. Recognize that every person's experience is unique. And we talked about that in the beginning about everybody sees trauma different. So this builds on what clients, staff, and communities have to offer rather than responding to perceived deficits. And we foster a belief in resilience. So with trauma also goes building resilience and the ability of individuals, organizations, communities to heal and promote recovery from trauma. So clients are supported in shared decision-making, choice, goal setting to determine the plan of action they need to heal and move forward. They're supported in cultivating self-advocacy skills. Staff are also facilitators of recovery rather than controllers of recovery. Again, voice and choice. And the organization actively moves past stereotypes and biases and offers access to responsive services. You leverage the healing value of connections, incorporates policy, protocols, and processes that are responsive to the needs of the individual served and the staff that are doing the service. And on the last thing I want to talk about with trauma-informed, it's also on the next slide. Trauma-informed approach, again, is essential for those in recovery. And Sampson's definition of recovery is a process of change through which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. So that's just a really brief overview and something that why we are talking about what we're talking about today. So I'd like to turn it back over to Tina.
Thank you, Marla. That was really helpful to hear an overview of trauma-informed care. Now, on the next slide, we'll talk about drug testing and how that can be trauma-informed. And we'll begin with the START drug testing principles and practices. So in START, we acknowledge that substance use disorder is a chronic condition from which people do recover. Parents served by START often have moderate to severe substance use disorder for which abstinence or medication-based recovery paths best prioritize child safety. We know that the use of drugs and alcohol alone does not mean that children are being abused and neglected. And when families come to the attention of child welfare, we believe child welfare should provide supportive services as opposed to punitive oversight. We see drug testing as one of those supportive services, and so do many of the parents we serve, believe it or not. Many of the interviews we do with START parents, they tell us that besides their family mentor, their worker, maybe the treatment they received, an important aspect of START was the drug testing because it provided accountability. We like to think about it as supportive accountability. Parents really appreciated that they didn't feel judged by the team in the process, but rather they felt supported in their recovery. Now, that's not to say that there weren't times along the way that they weren't happy about drug tests, but in the end, they saw them as helpful. So you'll get to hear some of the ideas today for making drug testing supportive and helpful. So on the next slide, I mentioned the components of START earlier. So let's look at how those components in START are trauma-informed and how they help support trauma-informed drug testing. So START family mentors, they play such an important role as they share their lived experience in recovery and child welfare. They can help alleviate fears or worries that parents might have about drug testing, talking through the process and any feelings that the parent might have, helping them feel as comfortable as possible when the tests are collected. Shared decision-making meetings are super important as we work together with the family to figure out how to respond to positive test results. Again, a strength-based approach is used. We include the family's supports and we collaborate with treatment providers in this process. One of our primary goals is to keep families together when it's safe and possible. And we go to great lengths to avoid family separation because we just know how traumatic it can be for both kids and parents when that happens. If there's no other option but to remove a child, we make sure there's quality family time to help alleviate the trauma and really support that parent-child bond as we work towards reunification. We also help avoid re-traumatizing families by keeping continuity of services. We know it's really hard on families to get shifted from worker to worker, having to retell their story and build trusting relationships. So our motto is once a start case, always a start case, meaning that we do not give up on families just because they're not doing well. We keep on going. We also use motivational interviewing and a non-judgmental approach throughout the life of that family's case. We play to people's strengths and we build on the good things in their lives. Families we've worked with through the years tell us that START has a different approach to working with families and one they appreciate. And finally, we ensure that parents and children are screened for trauma-related symptoms like Marla just talked about, and that they're provided with trauma-specific treatment when indicated, like seeking safety or trauma-focused CBT. On the next slide. So drug testing is included in our fidelity standards for START. It's just one piece of information that START considers when trying to keep children safely in the home, along with behavioral observation, treatment progress updates, and collateral information. Our standards include the use of regular random drug tests as one of the many strategies for reinforcing early recovery and to document drug and alcohol use and abstinence. In a non-judgmental manner, participants should be asked before testing about their substance use and what the results might show. And then the results should be discussed with them afterwards, including whether they were as expected, affirming negative results and the progress that they represent, or discussing the next steps in the event of a positive test result. Because experiencing a return to use is expected oftentimes as part of substance use disorders, START addresses a return to use or continued use in a thoughtful way that addresses child safety, but also considers the need for a change in the treatment plan. Drug testing for START parents is weekly for the first 60 days or during that intensive part of treatment, and then less frequently every other week as the team agrees the parent's more stable, is shown by treatment participation, negative drug test results, and the absence of any concerning behavior. Now, we know that some systems test 2 or more times per week. So the American Society of Addiction Medicine, or ASAM, recommends that testing should be done at least weekly during the initial phase of treatment and when possible on a random schedule, decreasing as recovery progresses. In START, we find that weekly testing is adequate because we're also in the home at least once a week, and oftentimes more than that. Parents are also involved in intensive treatment at that time. So drug testing can be conducted by the treatment provider, child welfare, or a third party, with results being conveyed to all the parties as quickly as possible so that child safety can be addressed if necessary. Sites should collaborate with other providers and systems like the courts or treatment or probation to share test results to reduce duplicate testing, which might require that parent to participate in multiple testing per week. Random testing means that the individual being tested does not have advance notice of the test. The ideal random system has the parent call daily to see if they're required to test that day or if they're notified on the day of the test. A random testing pattern helps to reinforce early recovery behaviors because reinforcement, when it's expected, can be more effective than reinforcement that is expected. This concept comes from behavioral psychology and the idea of intermittent reinforcement. Also consider the reliability of tests, knowing that instant tests sometimes have false negatives or more commonly false positives, and that tests used to make decisions about child placement or that are included in court records, they really need to have laboratory confirmation using industry standard methods such as mass spectrometry. In START, we've removed the requirement that tests be observed and changed the guidance for tests to be carefully collected. That means using standards in which the sample is carefully collected to avoid alteration or substitution of samples. Careful collection might include using a private collection space that doesn't have water or other means for altering the sample, maybe having blue dye in the toilet. It also means having the parent witness the sealing of the sample and the paperwork. Being careful with samples is for the parent's protection too, so they know that it is their sample that's being tested. So why do we take observation out of our requirements? Well, it used to be the standard of practice for drug testing, but as the field of substance use disorder treatment has progressed and as we have become more trauma informed, we've realized in START that observation isn't really always needed and that it can be intrusive and re-traumatizing. In short, doesn't fit with the spirit of START that we want to practice. We don't want to perpetuate shame. And we know that so many of the parents we work with are dealing with shame over their substance use or for being involved in the child welfare system. And on top of that, just pause for a moment and think what it might be like to have to provide a urine sample in front of someone if you've had a history of sexual or physical abuse. Even for people with abuse histories, being required to show your private parts or having something in your mouth like a swab can really feel like an invasion of privacy. So it's so important that we're very thoughtful about this practice. So what does it mean that observed is not part of the START fidelity standard anymore? Basically, sites are just not required to do observed drug tests in order to do START with fidelity. Sites can still choose to do observed drug tests, maybe on occasion as needed, or maybe to abide by your local court requirements. We're providing this information about how to be more trauma informed so that each site can consider and discuss with their partners whether and when they'll observe drug tests. On the next slide, so we talked about what we require for drug tests and why. This slide shows our START minimum work guideline standard for drug testing. Now, if you work in START, this looks very familiar, but we want to point out a few changes. The purple arrow shows the box where observed was removed from the standard and replaced with carefully collected. You'll also notice that we added a timeline for weekly collection to be the first 60 days of treatment, since that's usually how long intensive outpatient treatment lasts. Teams should use their judgment, though, about whether to continue weekly tests after 60 days for a parent based on how they're doing. Other parts of the standard remain the same. Once the parent has stabilized, we can reduce tests to every other week. And as I mentioned on the last slide, we really do recommend lab confirmation for positive test results if the parent doesn't confirm that they used a substance. If someone begins using substances again, testing really should return to weekly, and additional tests can be requested if there are behavioral indicators of substance use. While we have some specific guidance for drug testing, there are many aspects of drug testing that we do not dictate and that are left up to the sites to decide for themselves based on community needs and resources. We don't dictate what lab you use, although for reliability, we strongly recommend using a CLIA-approved lab. We don't dictate what substances you test for. You should decide that based on the substances in your region. Regarding what cutoff levels to use, we just recommend using the lowest level that's affordable and to coordinate that among your partners. Testing can be conducted by whomever you choose, treatment, child welfare, a lab, or another organization. There should be a scheduling process. We recommend using a call-in system to randomize testing, but we know that's not always feasible, and there are other ways to do this. We encourage you to work with a medical professional or your lab for questions on how to interpret results. And regarding the method of collection, most of our START sites use urine test or mouth swabs or a combination of both. Urine tests have been the most reliable and widely used, but mouth swabs have become more reliable in recent years. So just make sure you use a reputable source for the kits and that the tests are conducted according to the instructions. And just to say, hair, sweat, and blood tests are not used as much, and usually just if there's a good reason. There are pros and cons to each, so you have to really think about the cost, the intrusiveness, the window of detection, and those sorts of things. We really encourage steering committee members to talk through drug testing and come up with a protocol that meets all START standards, as well as documenting who conducts the testing and how all parties are going to be notified about the results. Again, drug testing is a contentious topic, so it is a topic that we cover with our START sites in TA pretty regularly. And for those sites that aren't implementing START, we invite you to reach out to the National Center on Substance Abuse and Child Welfare if you're interested in more on this topic. All right, on the next slide, we want to talk about how we respond if there is a positive drug test. So if a return to use happens, it's important that the team not blame themselves or judge the parent, but rather recognize this is a situation that needs a quick and thoughtful response. It's a time of crisis for the family, and it's important not to overwhelm them. But it's also an opportunity to engage the parent in services and recovery supports. The family mentor, the peer, is key to keeping parents engaged, providing that support and involving them in the plan to move forward. The bullet on losing the parent, it's referring to a break in engagement or contact, but with the opioid epidemic, the concern is overdose, leading to a potentially greater loss. So again, keeping in mind when you respond to a return to use, don't overwhelm the parent, they're in crisis. We want to provide support and specific, clear direction. Involve the parent in the plan and move forward. Keep it simple. A plan that's individualized might include detox and stabilization. It might be contacting a sponsor or other recovery supports and keeping appointments with your treatment providers and child welfare just to keep folks engaged. On the next slide, in START, a return to use or a positive drug test is considered an emergency, and here's how we respond. We ask treatment providers to notify the START worker and the family mentor immediately upon learning of a positive drug test result or a return to use. When this happens, the START worker dispatches to the home to check child safety and to see the parent status, how they're doing. We might have to have an emergency shared decision-making meeting to develop a child safety plan and to adjust treatment and other supports that might be needed. On the other hand, if the START worker or family mentor learns there's a return to use first, they inform the treatment provider immediately so they can assist in the planning and next steps. The family mentor is absolutely instrumental in providing that support during this time and helping parents navigate this crisis. We take a non-punitive approach with the parent, understanding this is a really stressful time for the family and they need support. And I want to emphasize, START does not automatically remove children when a substance is detected on a drug test or there is a return to use. Instead, attempts are made to maintain child safety through a safety plan and adjustments to the treatment plan. At this point, the START worker and family mentor would return to weekly home visits to kind of keep the family engaged and to provide that ongoing support until the family stabilizes. We also revisit and update the recovery management plan with the family at this time. We work incredibly hard with families to avoid removing children. And when we aren't able to maintain children in the home, the team works hard to help the family reunify in a timely but safe manner. And on the next slide, a few more thoughts on drug testing as an engagement tool. I want to think of drug testing again as an opportunity to engage parents into the treatment recovery process. When we approach testing with this mindset and use person-first, strength-based language, it helps minimize any shame or stigma that the parent might feel. The recovery process is hard, and we want to encourage parents in their journey, lift them up, and help them see that they can get to a place of healing. When a drug test is negative, meaning it doesn't detect a substance, we offer positive reinforcement and recognize the parent's accomplishment and offer encouragement and continued support. It's really an opportunity to discuss with them and really reinforce what's going well. Now remember, drug testing is limited in its scope of what it really tells us. It's simply a snapshot in time, and workers really need to be observant and collect information from collateral context to complete a full assessment of what's happening. Parents may test negative for a result, which tells you that in the specific detection window that substance wasn't detected. But if they're displaying behavioral indicators that don't align with that result, like missing appointments or sudden changes in behaviors or attitudes, just to name a few, this might be an opportunity to have a discussion with the parent about what you're observing and what you're hearing from collateral contacts. Really important that we're not making assumptions when we go into this discussion with parents. When we have an open, honest, transparent discussion and continuously engage with the parent to explore their progress, it helps build trust, and you can help determine how to best support them in their recovery journey. All right, I'm going to hand this over to Lynn now.
Thanks, Tina. I have to say, as a therapist who specialized in substance use and trauma treatment, that this topic is just really near and dear to my heart. So I'm happy to be talking about it today. I think it's important. So I'm going to talk about how we can apply trauma-informed principles specifically in drug testing. So I'm going to carry on from what Tina's already shared. We know that drug testing in particular can be an activating experience for some people, meaning that it can bring up difficult memories or feelings or trauma symptoms like flashbacks or nightmares. So urine tests can be particularly activating, especially with someone with sexual trauma in their history, but oral swabs could also be activating for people or any experience where the parent feels like they don't have choice or control over a situation. Trauma-informed drug testing means that we remember that most of the parents we work with could have a trauma history, whether they've disclosed it to us or not. And so we'll be careful with everyone we work with. It also means that we'll be sensitive to the needs of each person we serve, making accommodations as needed so that they can feel safe as they receive services with us. We've pulled together some trauma-informed ideas for you from the National Center on Substance Abuse and Child Welfare, and also from a group in Oregon that does really excellent trauma-informed work. We know that many of you may already be implementing lots of these strategies, but some of them maybe you haven't considered yet, and some can be relatively easy to implement. So on the next slide, and the next one, there we go. So let's think first about safety. It's important to remember that both parents and staff can be re-traumatized during the process of conducting drug tests. So we want to be careful with both of them. So here's some ideas about how we can support physical safety and emotional safety before, during, and after a drug test. First of all, this might be a no-brainer, but ensure that the facilities are clean. And make sure that the procedures are really clear to both the staff and the parents, maybe written out, maybe posted, or given as a handout before the test. Ensure that your staff are trained in the testing procedures and aware of the potential to re-traumatize themselves or parents. Provide a variety of testing options just in case someone is activated by a certain kind of test so that you can use a different kind instead. Give participants plenty of time. We know that this can be challenging because we have staffing constraints, but consider maybe having an area for parents to have a little extra time before the actual test if they need it. Respect their privacy, both in the testing room, but also in common areas of the testing site. And close off the restroom to others while conducting drug testing, just to allow for privacy and for people to feel safe. On the next slide, let's think about how we can ensure transparency about the process, because that helps to develop trust with the people we're working with. So take your time to clearly explain all the things before the test. Know that you may have to explain more than once, because when we're scared, sometimes we have trouble taking things in. So talk about the why. Why are you asking them to drug test? What's the purpose of the test? And who are the results going to be shared with? What substances is the test screening for? And then how and when will they get the results of the tests? Like if there will be instant test results, will they get those results immediately? Or do they have to wait for a confirmatory test to come back? And then also talk with them about who will get the test results besides the parent. So think about allowing time before and after the test for questions and for clarification, and assure there's a feedback loop for them to get questions and complaints answered in a timely way. And then let the participant see that sample being closed and labeled so that they're really sure that it's their sample. Next, let's look at being collaborative. Part of being trauma-informed is building relationships and sharing power. What does that mean for drug testing? So you might think about coming up with a list of options that can be available to parents. Then talk with parents about areas where they can have decision-making power in the process. You might think about whether there could be a conversation during the test. Maybe that would make them feel more comfortable. Whether they'd like to have water running, whether there could be music in the room with them, and then maybe even if there's a choice about which staff person conducts the test. Ensure there's a process for participants to have feedback about what works well or what could be improved to help them feel safer in the process. And then try to have staff conduct the tests who the participants feel comfortable with and who represent the community that they come from. On the next slide, let's look at empowerment. Restoring personal power, voice, and choice is really important for people who have survived trauma. let's think about ways we can allow for power sharing while promoting accountability in a non-punitive way. Like, let's maybe find ways for the participant to be part of making decisions. For instance, if a urine test has to be observed for some reason, maybe consider what can be flexible about the process. Like, can they choose whether to wear clothing? Are there options about maybe privacy gowns? Could there be observation through a mirror or a window? Could they face opposite directions, perhaps? Or maybe even they would like to have a support person with them in the room. Also, it's important to have other testing options available for people who find urine tests or mouth swabs activating. Ensure that they're aware of what their rights are as a participant in writing if possible. And provide multiple time slots for testing to accommodate schedules, because that can be stressful if you think you might miss the window. And also think about using non-stigmatizing language when we're talking about the drug testing and sharing the results with the parent or talking about them among ourselves. Like saying that a drug test is positive or an unexpected result, perhaps, instead of using a word that could be demeaning, like dirty. Next, let's look at how our family mentors can have a really important role with drug testing. Think about how peers or family mentors can support the process of drug testing. For instance, family mentors or other peers could help with communication with parents about the drug testing process and about the results of the tests, and then help the parent be thinking through what their next steps are for their recovery. Parents might also want their family mentor or peer available as a support person before or after their drug tests. And then make sure that family mentors and other peers are trained about trauma-informed care and about drug testing procedures so that they can be sensitive and supportive to parents. Next, a couple of ideas about discussing drug testing results with parents that might be helpful to you. It's important to see drug testing as a tool to help support recovery as opposed to a gotcha moment for the parent. The test offers the opportunity to engage in conversations with the parent about how they're doing, what's occurring in their lives, and determining a path forward. Some parents might be fearful that having a positive test will mean that child welfare might be removing their child from their care or canceling their family time. When there are discrepancies between the test results and what the parent self-reports about their drug use, have a conversation with them about that. Maybe ask them what they think will happen if the drug test result was accurate in detecting a substance. This question gives you some insight into what they're thinking, what they might be afraid of, and can help you determine what approach you might take next with that person. The use of exploratory questions can give you a glimpse of where their mindset is at the moment and maybe help them see how their behaviors are either getting them closer to or further away from what their goals are. If a parent's been testing negative and then test positive, explore what's going on. Explore what might have happened the day that they engaged in substance use. For a parent that's ambivalent about change, explore with them what they think would happen if XYZ were to occur. And finally, you can try scaling questions, like on a scale of 0 to 5, how confident are you about your ability to stop using substances? It's just one example. So on the next slide, I want to spend just a few minutes telling you about a guidance document that was released by the New York Office of Addiction Services and Supports in 2023. So Mark Raymond from Farnham and Oswego, New York, who's one of our panelists, you'll hear from him in a moment, told us about this document, and it really helped us change our minds about requiring observation of urine drug tests in the START model. I'll share just a few key points about the guidance, and then you'll hear from Mark as well about how the guidance impacted his practice. So they point out, which we fully agree, that drug tests are important for patient care, but they're not the only source of information we should be paying attention to. Results should be discussed with the patients in a supportive way rather than a punitive one. If a patient's not able to provide a specific specimen, consider collecting a specimen using a different kind of method. And directly observing urine tests should be a last resort, used only in rare instances for the person's safety and treatment, according to this policy guidance. So I'm going to turn things over now. So on the next slide, you get to hear from our panel. I'd like to introduce our moderator for the panel, Danya Flanoy. She is a senior program associate with us here at Children and Family Futures, and she has a wealth of experience in child welfare and START in particular, from her work in Cleveland, Ohio. And she provides training and technical assistance to several of our START affiliates. So Danya, I'm going to turn it over to you in the panel. Thank you.
Thank you so much, Lynn. A lot of great information. The first half of our webinar, and we're just going to take a little Q&A from the people in the field, the people that are doing this work, boots on the ground, so to speak, is what I like to call them. And after which we'll talk for about 20 minutes, and then we'll turn it over for some Q&A. So let me introduce our beautiful panel that we have today. First and foremost, we have Miss Felicia Hewen. Well, her camera is not on. I'm not sure what happened, but I'll come back and I'll go to Miss Kelly. We have Kelly Iskett. She is a START supervisor in Buncombe County, North Carolina. Next, we have Jessica Okolish, hope I pronounced it correctly, who is a START family peer mentor in Summit, Ohio. Okay, Ohio, I'm in Cleveland. And next we have, okay, Felicia, you're coming on and coming off. I'll give you one other, I'll come back to you again. And then we have Mark Raymond. He is a clinical director with Farnham Family Services in Oswego, New York. And so finally we have Miss Felicia I can't pronounce it. Come on, help me out.
It's Quinones.
Quinones, thank you. Who is the START Assistant Director in Kentucky. And Felicia, we can just hear you. We just can't see you right now. So hopefully when we get to your chance to speak, we'll be able to see your beautiful face. So first and foremost, let's there you go. Hey, Felicia, thank you. All right, so Kelly and Jessica, when you're in your role, how do you make drug testing experience supportive for the families that you're working with? And either Kelly or Jessica can take that question and toss it to each other to add their perspectives, because it's from two different perspectives, one as a supervisor and one as a family peer mentor.
So I'll go first. So when we have a START client that starts with us, I really like to be open and transparent with them about like what our expectations are and when screens are needed and the purpose of those screens. And just like the New York model, we really talk about screens being used as a tool to gauge like progress. And we don't want to use it as a harmful punishment towards somebody. We collectively come together and collaborate with partners to gauge progress, and so that we know if there's something that's needed more, or when somebody's started on an MAT service, sometimes there's continued use until they're stabilized. Like, we understand those things. And so really just having that communication with the client and having them understand the process. If they understand the process and the purpose, they're a lot more, agreeable to take the screen.
Yes.
I'll add, just piggybacking a little bit off of what she said. So here at our location, we rely heavily on our family mentors for that support. We recognize that involvement with DSS is scary and traumatizing, and now we're asking you to come screen with us on a very frequent basis. just trying to be very mindful of our trauma-informed care and our language that we're using. But our mentors, they assist with providing that support. We have a designated, what we call a lead family mentor each week for our drug testing, who's responsible for being present in our office during our screening hours. They don't handle the sample or do the collection of the sample, but they will get parents from our lobby when they check in, sit with them before and after. And our lab has shifted where we don't have instant results on our cups. They get sent to the lab, and then all of our samples go through confirmatory testing, and that can come 3 to 5 days later. Like Lynn was talking about, we try and offer an option for an oral swab, and just recognizing that life continues despite your involvement with the department. And if once a parent learns about screen day, if they're not able to make it that day or during those screening hours, we just ask that they communicate with the social worker or the family mentor, and we can look at approving them to come in a different day, and try and be as flexible as possible during this process.
Kelly, I hear you mention that if the parent is unable to complete the drug testing the day that they're asked to go, what happened? How do you handle situations where a parent miss the testing and does not communicate with the worker? How do you handle that? How does your staff address that with that parent?
So we try to not make the assumptions right off the bat that because they missed it, it's because they would have been positive or there was a return to use. So really just trying to have those open conversations about why was it missed? Were there barriers with transportation, illness? Hey, they just forgot to call. We're all human. And so we just really try and talk to the parent directly about what happened. And then pending why the screen was missed, and if they're willing to have that open conversation with us, then again, wanting to give them an opportunity to screen another day that week.
Good. Thank you, Kelly. And Jessica, just a final question regarding drug testing. How do you talk with parents? Oh, excuse me. No. What else do you see? What else do you take into consideration outside of drug testing to see how someone is doing in treatment or how they're progressing on their road to recovery?
I think it takes a lot of communication, and with the intensiveness of our program, being in the home weekly as peer mentors, maybe going with a parent to meetings, but really being there and listening and not judging. And screens or drug testing is just not our only tool. A lot of times we will see red flags, or we see successes, and like all of those little successes that might not seem like a success to one person, we celebrate those. Like, hey, you've made it. You got 1 week, hey, we had 2 clean screens, like, way to go. Like, really building up our clients as peer mentors and like working with our clients to understand like the child welfare processes, and that we're not trying to punish or harm. We're really trying to work together.
Good. Thank you. Thank you, Kelly. Thank you, Jessica. Now I'm going to turn it over to Felicia Quiones to ask her a couple of questions from her perspective as being a Kentucky assistant director. So as a director, you provide guidance to multiple sites across your state. Could you please just share an example of a guidance that you provided to staff about trauma-informed drug testing?
So really, we talk to all of our sites about slowing down, right? Slowing down that process, really critically thinking about each family in particular, not making it across the board. We need to know why we need to test. What does that look like? What are we looking for? What are we hoping to figure out? And are there other ways to meet the family where they're at and to meet the need that the team is wanting to find out? We want to make sure that they stay up to date on the screening processes facilities that they use. What is going on?
There we go.
you know what's happening there, since we don't provide our own drug screens. So make sure that we're going and checking those places out and make sure that they are in line with what we are aligned with. Don't assume that because parents will give pushback or resistance or express fear that it is resistance, that they just don't want to test. Talk through that with them, figure out what that is. And we do have a plethora of options to give families now, and talk through that with the families on what would be best way to meet their need.
Mhm. So thinking about this shift in STAR, because you've been in STAR for a while. And
Mhm.
so this shift and moving from you being more trauma informed when we're doing drug testings for our family, how do you plan as as assistant director to introduce this new guidance, shifting away from that observed drug testing to your two sites who sometimes we can, you know, get a little pushback from staff, but what is your plan for getting that support and introducing this to staff?
Well, what we know about the workforce is change is not great for us, right? We struggle with anything that's changing, and especially something as big as this. So
Mhm.
starting small, figuring out those pieces that we can have control over and implementing. Is it just giving more written and verbal consent and information about what the family or what the families can expect when they're drug screening, being mindful of the words that we're using so that way they're not harmful, having more conversations around what being trauma informed looks like, and then sprinkling in the bigger stuff, like maybe we should start talking about not having observed drug screens. We also want to start on bigger picture, like having people at the table so we're having these conversations and not expecting too much too fast, because change isn't easy and we need to move very slowly with some folks to get them on board, because not everybody is as ready as we are.
Absolutely. Great, great, great. All right, thank you, thank you. So
Yeah.
now, Mark, you are you're a provider, and so I think just hearing from your perspective, you shared the New York toxicology guidance with us, and START, as Lynn stated, it came out last year, and this guidance really helped shift our practice in START. So, what's changed in your agency drug testing practice as a result of this guidance that was released in 2023?
Okay, well, hello, everybody. I'd like to start by saying Farnham Family Services provides comprehensive services to people with substance use disorders in 4 locations within Oswego and Cayuga counties in upstate New York. That treatment consists of evidence-based practices, including but not limited to individual, group, family counseling, administered and prescription-based medications for opioid use disorder, MOUD, medical and mental health services within scope, and other wraparound services based on the unique needs of the individual served. We, like many providers, have traditionally observed toxicology screens. The intention of the screens observed is to ensure sample integrity. We rightfully believe that sample integrity contributes to informed clinical decision-making, patient and community safety, especially considering we're providing controlled substances such as methadone and buprenorphine, which help save lives. So when New York State OASIS issued this guidance that screening needed to be unobserved as a default, we were actually taken aback and even concerned. However, we implemented the changes to our policies and procedures, and to our surprise, there has not been any known traumatic fallout, and instead there have been benefits. Known to this room, a large percentage of SUD patients have experienced trauma, including sexual abuse, and Farnham's striving to provide trauma-informed services. Sometimes when a person can't provide a sample under direct observation, it really may be due to trauma triggering anxiety and other trauma-related factors, not because they're trying to falsify a sample. There are people who've actually chosen to avoid potentially life-saving treatment because of their inability to provide samples under direct observation. An additional benefit experience includes not needing specific staff available to provide direct observation, saving time and more. We use toxicology screening as an important factor, as mentioned, when making treatment recommendations and decisions. And we're confident some people will provide falsified samples. However, toxicology is one factor, not the sole factor. Patient presentation, including their appearance, their mental status, speech, cognition, gait, pupil size, other behaviors, reports, and more can be contributing factors. And knowing the chronic and progressive characteristics of the disease of addiction, We also believe that if someone is using and falsifying their screens, such evidence will usually and eventually surface. Furthermore, when addressing toxicology, we intend to address it in non-punitive ways, as was mentioned, use the non-stigmatizing language, and include the patient in addressing both positive and negative results. With that said, our motives for patient and community safety do remain legitimate. While our default practice is to provide unobserved screens, we continue to provide some observed screens when clinically indicated. Situations where we might provide a direct observation could include, but are not limited to, when a patient presents with an impaired mental status, but is denying use and testing negative for drugs or alcohol. Or perhaps they're being prescribed a medication such as methadone or buprenorphine, but they're testing negative for that prescribed medication. Or maybe they're providing a cold or questionable sample to us. If we receive a significant report from somebody like a stakeholders, CPS or probation or other criminal justice entity, we may provide a direct observation screen. But I should add that direct observation still does not even guarantee that a sample will be 100% legitimate. There are many creative ways to falsify screens. Observation is one way to mitigate that, but it's not going to guarantee it. So considering all these things is a healthy approach to treatment anyway. I guess the last thing I would say is our involvement in the START program has been very valuable. Our clinic staff have never worked more closely with our local child protective services. The Oswego County DSS staff have been wonderful to work with, and START actually helped bring us closer together with strategies to help keep families together when a substance use disorder is present, balancing child safety and recovery at a whole new level. In my opinion, this updated toxicology practice fits very well with the START program. It's balancing patient engagement, person-centered care, considerations for trauma, and still has room for direct observation when clinically indicated, and perhaps safety as an elevated risk or concern. We also understand that there could be a wide range of thoughts on this topic, different laws per state. So we plan to continue to monitor it, learn, and adapt the best we can, including some risk and benefit analysis.
Well, thank you, Mark. That was a wealth of information you just provided. And one thing that I can say that you ended at the end that is probably the heart of START is that collaboration. And what I heard you say is that this, implementing START in Oswego County has really brought your treatment center and Oswego County DSS closer together, because when you're in this field, we all work in silos here, and so bringing us close together, collaborating to do what's best for the families that we're serving in each system. So great. Thank you guys for such a wealth of information and really sharing your knowledge from the front lines, as I would say, at different levels. And so with that, I am going to turn it over to Tina, because we're going to have spend some time with some Q&A. And thank you, everyone. Thank you, panelists.
That was excellent. Thank you, Danya, and thank you, panelists. I'm looking at the time and I want to get us out of here on time. So I'm just going to pick from, we have a variety of questions, but Jessica, I'm interested. Do parents, first of all, let me just preface this with, I know how close parents get to their family mentors and how much they value that support, that they're very open and transparent. So my question is, do parents ever tell you that they're using substances in advance of the actual drug test? And if so, how do you handle that?
Yes, they do. It happens quite frequently. So I think it goes back to that initial, when we start with a client or with a family, we talk about that honesty, that transparency. If you are going to be taking a screen, we would much rather have you go, hey, you know what, this week I didn't do so great. So we can navigate through that. Then next week when the result comes, and we're, oh, wow, we didn't even know, or I saw some behaviors, but they're just not really forthcoming yet. So how can we explore that with that client? We see that quite a bit, where we have that relationship built with the client and they're willing to go, hey, you know what? I want to take accountability. I messed up. This wasn't a good past week. And we embrace that. thank you for being honest with us. Okay, tell me what happened.
That's excellent. I mean, it really does show the trust that you build with them. And I think it also shows that families understand that we're not just going to yank children out of their care when there's a positive test, but that we're going to be thoughtful about it. So thank you. I'm going to do one more. And Kelly, this one's for you. What sort of resource person do you turn to when you aren't sure how to interpret test results? Because I think that's a big question for all of us in child welfare.
Yeah, definitely. So our current lab that we use, we have a pretty good partnership with them, and to where we can pick up the phone and call them or send them an email if we have some questions about results, a substance, levels, what does this mean? Because we switched labs, myself and our other START supervisor here at our site, we received a mini training on how to read the results, because we're not medical providers and this isn't our background. So that has helped. And again, just knowing that we have connections, if we have questions, we can reach out to try and get more information.
Yeah, really helpful. Thank you for that. And I wish we had a little more time, but I want everybody to know if you submitted a question, we will respond to you individually. Just want you to know that. And again, I want to thank our speakers and our panelists. This was amazing. And every time I talk about this and prepare for this today, I just learned so much. And so thank you. All right. I think we have another slide. I just want to reflect for a moment, and I want everybody to take a moment and think, what will you do differently tomorrow based on what you learned today? Maybe you'll take this back to your team. Maybe you'll have a larger discussion with your community. I hope that you've found something that's meaningful and that you can take back home for your own practice. And please contact us. Any further information that you might like about START, or if you'd like to become a START affiliate. And with that, we conclude today's programming. Thank you, everyone. Have a wonderful day.